Hey there, this is Dr. Evan Osar, founder of Integrative Movement U, the online resource dedicated to helping you develop your expertise by applying the principles that govern human movement, incorporating the industry's best practices, and by developing the perspective so you can be the expert your current general population clients, as well as your potential clients, need, want, and will pay for. Thank you so much for tuning into this webinar, where we will be looking at the function of the gluteus medius and its role in frontal plane stability. Understanding how to help your clients develop optimal gluteus medius function is necessary for helping your clients develop control whether they are standing, walking, running, and or exercising. The gluteus medius is thought to be primarily a hip abductor, and of course, it does do this function. Many of the exercises our clients are doing are designed to specifically work this abduction function. While many of these exercises will indeed work the gluteus medius in this function, we need to ask ourselves if they're actually helping our clients improve their function once they get into the upright position. In this webinar, we will be discussing the functional role of the gluteus medius and how the inhibition of the glute medius leads to loss of frontal plane stability. We will look at the research around common gluteus medius exercises and what we need to take from these studies. Because as we will discuss, just because an exercise increases gluteus medius activity, it doesn't always mean it will help your clients when they are in the upright position and or standing on one leg. And of course, I will be sharing with you the strategy we use with our clients so you can help your clients perform at their best while helping them improve gluteus medius activity and in the process, improving frontal plane stability. There are three primary things I want you to get out of this presentation. Number one, discuss the functional anatomy of the gluteus medius and how this function relates to optimal biomechanics and control of frontal plane stability. So essentially, we'll talk about the anatomy, biomechanics, and control. Some of the information I shared with you in the previous webinars of the hip will be helpful to review as well. We'll be looking at the functional role of the glute medius and how to develop the corrective exercise as well as the progressive exercise patterns needed to improve optimal function. Number two, discover the fundamental corrective exercise patterns that we use to improve gluteus medius activity. And I'll be sharing with you how to integrate this function into the progressive exercise patterns, including band walks and bench step outs, to the patterns we use with a lot of our clients. And finally, develop your expertise so you can be the go-to resource for your clients and help them develop the optimal stability and control they need to move easier, decrease chronic hip and back tightness, and accomplish their health and fitness goals, whether they are to walk, run, and or just function in everyday life without chronic tightness and discomfort. Let's get started. In order to look at the gluteus medius function, we have to look at the pelvis and hip complexes. And we have to consider both the control at both the hip as well as the pelvis, because these regions work together. And in order to have optimal function, we need to look at how the femur relates to the pelvis and how the pelvis relates to the femur. Because when we talk about the hip, we're talking about the femoral head as it relates to the acetabulum of the ilium. So we have to look at both the open chain function, or the function of when the pelvis is stable and the leg is moving, and also when the foot is on the ground and the pelvis is moving around the stable lower extremity. So in order to have proper function of the pelvis and hip complex, we must have optimal function of the entire gluteal complex. And this refers to the gluteus maximus, the medius, as well as the minimus. So we're going to look briefly at the maximus, minimus, and also the TFL. However, we'll focus most of our attention on the gluteus medius. Because in order to look at gluteus medius function, we have to realize that it's not working in isolation. So even though we're going to focus primarily on gluteus medius in this webinar, what we really want to be thinking about is how does the gluteus medius function as part of the gluteal complex in the control of both the pelvis and hip. And we'll discuss this briefly throughout this webinar. So the gluteus maximus and TFL are the superficial layers, myofascial layers, of the pelvis and hip complex. So gluteus maximus is a big, thick muscle, as you know. It comes off the iliac crest. So it comes off the posterior aspect of the iliac crest. It also comes off the sacrum, so the iliac crest here, sacrum, and it also comes off the coccyx. And then these fibers blend into the posterior aspect of the iliotibial band. Now the TFL comes off the anterior aspect of the iliac crest, and it also blends down into the iliotibial band. So these muscles collectively can also abduct the leg, so both of them contracting together if your leg is off the ground can abduct your hip. But more importantly, in function, they also will control that frontal plane stability, or that stability that we need when we stand on one leg. So both the glute max and TFL will pull up on the IT band to create stability, especially when we get into single leg stance. And these muscles are also important for controlling the lower extremity when we start to pronate, or when we're walking, squatting, lunging, standing on one leg. It helps control pronation. So a lot of the things we see down at the ankle, knee, and foot will be related to loss of control of these muscles in controlling that lower extremity. So even though we're going to be discussing a little bit more closely the glute medius, we also have to consider that these muscles work as the superficial layers of that lateral hip complex. The muscle we'll focus on more in this webinar in particular is the glute medius. And the glute medius is essentially the middle layer of the pelvis and hip myofascial complex. It originates off the superior and lateral aspects of the ilium. So you see it muscle right here. So it comes off underneath the glute max, and it also comes off right behind the TFL. And then it comes down to insert into the greatotrochanter. So if you actually slide your hand from your iliac crest, the lateral aspect of it, slide it down till you hit your greatotrochanter, or that bone that's most lateral, the bone that sticks out the most just below your glutes, that's your greatotrochanter. That's where the glute medius is inserting to. Now let's look at the function of this glute medius muscle. Well, as you know, and as we've talked about, the glute medius is an important frontal plane stabilizer of both the pelvis and the hip, meaning that it can control, or it controls, the position of the pelvis over top that femur, especially in standing, upright posture, and in gait. So it really helps to control once we get on to single leg stance, or standing on one leg, which happens during gait. It also will provide or perform hip abduction. And this is what we're talking about, is when the hip is moving, the pelvis remaining relatively stationary. So if you're lying on your side and you abduct your hip, or you lift your leg out to the side, your pelvis is fairly stable and your femur is moving around your pelvis. So the femoral head is moving around the pelvis. So it does hip abduction, and we know that function. And a lot of exercises focus on this function of the glute med. However, it will also lateral tilt the pelvis. So this is when you're standing on one leg, and if you start to tilt your pelvis towards the leg you're standing on, it creates that lateral tilt of the pelvis. So now the pelvis is moving, and the femoral head, or the hip joint itself, is becoming the stationary point. You're moving the acetabulum over top the femoral head. So again, if you're moving your leg and your pelvis is stationary, that's hip abduction. And if your leg is stationary and you're moving your pelvis, that's lateral tilting of the pelvis. The anterior fibers of glute medius will do internal rotation, so that they will also assist internal rotation of the femur during functional patterns. And if we want to just rotate our leg in for any functional activities like kicking, striking, throwing our leg out in front of us. The posterior fibers will do more external rotation. So those fibers are more responsible for controlling a lot of the internal rotation that happens during pronation, during the gait cycle, for example. So again, these fibers will help the glute max in its function of controlling the lower extremity as we load up. So again, the glute medius has a very involved function. But remember, it's also functioning as part of the greater gluteal complex. It's never working in isolation. Below the glute medius is the glute minimus, and it's the deep level of the pelvis and hip complex. So there's this little tiny muscle here that comes off the lateral, slightly anterior portion of the ilium, and it also comes down to insert into the greatotrochanter, but it also fascially blends into the joint capsule. You don't see here, but there's a joint capsule surrounding all our synovial joints. So the hip joint, being a synovial joint, has a joint capsule to provide support and keep the synovial fluid inside the joint. So the glute minimus inserts directly into the joint capsule to help stabilize the capsule and also provide additional support for the hip joint. In fact, it probably works a little bit like the supraspinatus of the shoulder complex in that it probably helps to centrate the femoral head in the acetabulum as we go into any kind of hip patterning. So the function of the glute minimus is, again, stabilization of the pelvis and hips, similar to the glute medius. It likely functions similar to the supraspinatus of the shoulder in that it helps set the femoral head within the acetabulum, and it pulls upon the joint capsule to get the joint capsule out of the way and help provide more support to the joint through a variety of ranges of motion. And the joint capsule also blends with the ligaments of the hip complex to help provide additional support. So unlike the shoulder capsule, which tends to be allow a lot more freedom of motion, the hip joint capsule tends to be a little stiffer because we need more support in single leg stance than the shoulder requires. The glute minimus is an important part of this functional control. So collectively, the gluteal complex, including the TFL, are involved with frontal plane stabilization. And what we mean by that is it controls the pelvis swaying side to side. So this is frontal plane control to keep the pelvis lined up underneath the thorax as we get into single leg stance and as we do a variety of functional tasks like walking, running, and exercising. Now just briefly about the biomechanics. When is the glute medius most active during gait cycle? Because again, if we're going to look at what do muscles do, when are they most active, we have to kind of look at when are they most active during functional activities. And here's just a sample of when we were walking. So when the heel comes down into the ground, so we call this the heel contact phase gait. So we're looking at this purple highlighted leg here. So when the heel comes down and the foot starts dropping down towards the ground and we start to bring our weight onto this front leg. So this is, we go from heel contact to foot flat to the loading response. The loading response is basically from this point to this point right here. When our weight is really getting onto that forward leg and we need to support ourselves in single leg stance. The glute medius is the most active during this phase, and it's really trying to control, along with the whole gluteal complex and the TFL, is trying to control the position of the pelvis and support the body weight over top this forward leg, and control it as we transition and swing that other leg, the opposite leg, forward. So we need that a huge amount of frontal plane control, and we see what people look like when they lose control. Their hips start to and the pelvis start to sway side to side as they're walking. You may even see them compensate by bending their trunk over their stance leg, and we'll look at examples of this further along in the webinar. So again, just realize that the glute medius is most active as we get into from bilateral stance or standing on both legs as we get into single leg stance during the gait cycle. Because keep this in mind as we start to look at the exercises that most people use to train the glute medius, and that's mostly hip abduction. And I want you to think about how much hip abduction is actually happening at this moment. And then, if that's the case, is hip abduction the actual best way to train the glute medius? Or is there a better way to train the glute medius? And we'll talk about that. But keep this slide and keep this function of the glute medius in mind. So again, it's most active during the mid-stance phase of gait. Not optimal control of the gluteus medius. And this is what we call, in the physical therapy, chiropractic world, positive or non-compensated Trendelenburg's gait. And that's when the pelvis drops opposite to the side of weight bearing. So what happens is as a client gets on one leg, or single leg stance, their pelvis drops. So the pelvis on the opposite side, so this client is standing on her left side, and the right side of her pelvis drops down, and it looks like her hip kicks out to the side. Now, a lot of people walk that way on purpose, mainly models, and that's that sexy gait that the models tend to have. Their pelvis just swishes out side to side. and they just basically have this pelvic or positive Trendelenburg gait. Their pelvis, they purposely are just swinging their pelvis side to side. Looks real sexy, not very functional, and will create problems if this pattern perpetuates. However, a lot of our clients demonstrate the same kind of pattern, oftentimes not purposely, but because their glute medius, as part of an overall system, is not controlling that pelvic drop. So they're swaying that pelvis out within the frontal plane. Now, there's another way a client can compensate for non-optimal gluteal control. And this is what it will look like in gait. As this client gets onto her forward leg, you see the pelvis drop and her pelvis will shift out to the side. And again, you'll see this if you really, if you have clients that run, put them on the treadmill, videotape them with their iPhone or their smartphone or your iPad, and then slow it down, and you really see this big shift happening. Because sometimes it happens so quickly, we start to miss it. But the video, but actually videotaping it really will give us a sign as to how well or how well they're not controlling stance phase of gait. This could be a very valuable tool for our clients, especially if they're having hip problems and or they've been told they have gluteus medius weakness, because then they can actually see what we're trying to improve with their glute medius exercises. And it can also be a sign or a valuable tool, feedback, as to when you start strengthening or improving glute medius function, is it really improving their function in the upright position? So before and afters are also very valuable for your clients to see. Now, another way that clients can compensate for non-optimal gluteal function is they can have a compensated Trendelenburg's gait. And that's when they do lateral flexion or side bending of the trunk over the support leg. So either the pelvis drops out, or they can compensate by side bending their trunk over top the stance leg. And this will hide or mask a lot of glute med or gluteal complex stability issues. These are the clients that also will tend to have trigger points in that QL because they're overusing that QL and erectors to side bend themselves on top of the stance leg. In running, this is kind of what it looks like. Client's pelvis drops, and then they compensate by shifting their trunk up and over top that forward or stance leg. And again, this is why clients will have a lot of trigger points in their low back, whereas the opposite clients, the clients that had more of the pelvis dropping, they will tend to have more knee, IT band type problems and foot type problems. These clients here with the compensated Trendelenburgs will tend to have more back tightness and discomfort in the spinal muscles. Now, why do we lose gluteus medius control? Why do so many of our clients lose gluteus medius control? Well, a lot of times it's because of non-optimal exercise habits or loss of frontal plane control. And here's an example of me doing a side lunge here, not controlling my pelvis. You see my pelvis is sticking way too far out here, so it's going beyond my foot. So therefore, we get overstretching of the glute medius and the lateral posterior capsule, especially if this becomes my perpetual pattern, kind of like it's doing with this girl here. You can see she's got optimal alignment of her hip, knee, ankle, foot, but then you see the pelvis drop down. So she's actually creating herself or feeding in or driving in this pattern of not controlling her pelvis. And that's why it's so important to look at your clients, how they're exercising, and making sure that they line themselves up properly, that the TPC is controlled, that the thoracolpelvic canister is controlled and level, that the pelvis is level relative to the lower extremity. Because a lot of our clients, if you just look at the hip, knee, ankle, foot, you're like, oh, that's in perfect alignment, but you don't, or you'll miss that pelvis dropping down and out. So that's why it's important to look both from the side as well as the front and the back, so you pick up these changes in our clients' pelvic alignment, so we can see when they're not maintaining proper alignment. Why else do we lose glute medius control? It's not optimal use of gluteus medius in standing. A lot of women in particular, guys do this too, tends to be a little bit more frequent in women, is they tend to hang off their lateral hip. So they're just kind of hanging here, overstretching their lateral hip complex. So they're stretching their TFL, glute medius, glute minimus, glute maximus fibers, and the fascia around the lateral hip. And then they sort of stand like that, and high heels will just exacerbate that. And again, it looks sexy, it looks cool, It looks trendy. However, it's also creating a problem that perpetuates as the client starts to exercise. So a lot of clients will take these standing postures into their movement patterns, and that's when it starts to become a problem. It's not so much of a problem if the client is standing like that, it's when this pattern of standing becomes so prevalent that they start taking this into all their fundamental movement patterns, how they stand, how they walk, how they move when they exercise. And that's really where the problem starts to stem from, is the overstretching, the chronic overstretching from just standing there and from perpetuating this pattern. And a lot of women will develop this because as they as they have children, they'll hang their child off on their hips. So you'll start to see these women, they'll stand like this to prop their baby up on their pelvis as they can free up this arm to do work. And it's a very easy way for them to stabilize the child without holding the weight of the child. But then again, it also keeps perpetuating this side bending or this frontal plane loss of control. And even when these children grow up and these women are done raising and lifting their children, I mean, not that they're done raising their children, but they're done lifting their children, their small children, they still tend to have these patterns. And we can often see if they're a right-handed female, they'll tend to have their hip kicked out to the left side, kind of like this woman right here. Because if you're right-handed, you want to support on your left side, and then you want to free up your right hand to do things like cooking, cleaning, using fine motor tasks with your more dominant hand. So generally, right-handed women will tend to kick out on their left side, so they'll have overstretching of their left lateral hip and hip complex, and they'll have shortening of their right side. Not all the time, but generally that's the pattern we see in the majority of our patients and clients. Why else do we lose glute medius control? Is when we lose control of the core or the TPC, the thoraco-pelvic canister. And that often leads to gluteus medius inhibition. And you see 3 examples of this. In this runner here, not aligning her TPC. This runner here, not aligning his TPC. Me doing a single leg exercise here, not controlling my TPC. You see twisting of my pelvis and not aligning my pelvis to my thorax. And that will often lead to gluteus medius inhibition. Remember, anytime the low back is stressed out by non-alignment, non-control, sitting too much that puts your pelvis into a posterior tilt and starts to stress the lower back nerves, especially the lumbar nerves that go to your glute medius, will oftentimes get glute medius inhibition. What we find in the majority of our patients and clients is that when we teach them how to control their TPC, or that thoraco-pelvic canister, when we teach them how to align, breathe, and control the principles of the integrated movement system and develop better TPC control, all of a sudden their weak, quote unquote, weak glute medius starts to fire up and become strong. So it's not so much that the glute medius is weak, it's more inhibited by non-optimal control of the TPC. So we're not going to focus on that in this webinar, because our focus in this webinar is to work the TPC. I'm sorry, to work the glute medius, not the TPC. However, remember that every time you work the glute medius, we're also wanting to work control of the TPC. And you'll see through the exercise progressions that we use later on in the webinar that the TPC is always the first place we try to align and control. Because without alignment and control of the TPC, you will not get good you will not get good glute medius activation. So again, start with proper TPC alignment and control. So your IMU key point: improving glute medius function is loss of core or TPC stabilization leads to glute medius inhibition and loss of frontal plane stability. So our first and primary goal is to improve TPC control. Make sure the client can align and control the TPC before you ever start working on glute medius. And don't ever have them put them in an exercise or pattern where they cannot control their TPC, because you're just strengthening the glute medius around a non-functional TPC, and that will go back and start to inhibit function of the glutes when they need them. So again, develop optimal alignment, breathing, and control, and then take that into their functional glute medius patterns. And we'll do that through the rest of this webinar. So recap. Frontal plane control is key for stabilization in the upright position. So whether your client is standing, walking, running, and or exercising, or just performing activities of daily life, they must have frontal plane control so that they have optimal alignment of their pelvis, hip, and spine without overloading any soft tissue and or joint structures. The glute medius is a significant contributor to frontal plane stability. The important concept I want you to take home from this is that the glute medius never functions in isolation. It's working as part of the whole gluteal complex. It's working in part with the glute minimus, maximus, TFL. It's also working with that thoracolpelvic canister to maintain the pelvis while in single leg stance. So while we're going to be talking about the rest of the webinar about training the glute medius, we're really focusing on the glute medius as part of the entire system, not just isolating the glute medius. The TPC or core is responsible for creating the proximal stability required to enable proper gluteal function. Control first prior to working on the glute medius. Make sure the client can stabilize it, align, and control their TPC prior to working on the glute medius. Otherwise, you're just strengthening a non-functional alignment, and that will just lead to further inhibition and actually develop more dysfunction rather than more optimal function. So our integrative movement corrective exercise strategy is first we want to assess, then we want to correct, then we want to integrate. So first we're going to assess for pelvic and hip stability, comparing side to side. Then we want to apply the appropriate glute medius activation strategy. Make sure we're using the best exercises or the most appropriate exercises to get the glute involved into its role in developing stability and control of the pelvis and the hip. And then we want to integrate the glute medius and the entire gluteal complex into fundamental movement patterns. And we're going to look at the step out pattern as well as looking at the lateral band walk in this webinar. The single leg stance is one of the best assessments to assess control of the thoracolpelvic canister and how well the body is functioning or the system is functioning to control single leg stance or standing on one leg. What we're looking for is that the TPC stays aligned, meaning that the thorax stays lined up over top of the pelvis and the TPC stays lined up, relatively speaking, over the base of support or the feet. The pelvis should remain level. So when the client stands on one leg, they maintain the thorax over top of the pelvis, and the pelvis stays level. The stance leg remains aligned. So the standing alignment in bilateral stance should be very similar to what we see in single leg stance, that the hip, knee, ankle, and foot stay relatively aligned. And also we're looking for minimal weight shift, meaning we don't want the client to have these big sways from side to side to get their weight onto one leg, because that also shows us a sign of non-optimal strategy. There should be a minimal weight shift to get onto one leg. And one more thing, if you're taking notes, is to note that when your client stands on one leg, their height should be exactly the same, meaning that the height of their head should be exactly the same. You should not see a decrease in their head alignment. So if you drew a line on the wall from the top of their head, when they stand on one leg, they should maintain the same height and even get a little bit taller. And that tells you that they're actually using a good strategy. If you see them shrinking down, then that means that they're over flexing, over gripping, and losing control, so they can't maintain that vertical height. So look for the height as they get onto one leg, and that tells you about their level of control. So again, we want to see that everything stays lined up and that there's minimal weight shift to get their weight onto each stance leg. And generally, you'll see more challenge on one side versus the other. And generally, there'll be more weight shifting to get their weight onto their weaker or more inhibited side. So as we discussed, the common compensations is you see hip unleveling, where you see that hip start to drop out to the side and or that pelvis start to drop down on one side. Or if the person compensates, you may see the trunk shift over their stance leg. You may see them side bend their body over top their stance leg. You may also see loss of lower extremity alignment. So you may not see the hip, knee, ankle, and foot line up anymore. You may see excessive internal rotation, kind of what this client is showing us right here. You see that popliteal fossa is not facing back towards us. It's significantly internally rotating. And or you may see excessive gripping, like this client's also showing us, excessive gripping in her erectors. A lot of clients may have excessive gripping in their lateral or posterior hip complex because they're overusing these muscles to try to gain support. You should not see a big change in how much the muscles have to activate in single leg stance as to when people move from double leg stance or standing to single leg stance. There should not be a significant change in the amount of activation of the muscles. Yes, there should be a little increase, a slight increase, but not a significant shift in the amount of activity the muscles have to do. It should be a very effortless transition from standing on two legs to standing on one leg. However, for most of us, most of our clients, it's not a simple and easy transition. So that's why this becomes such a really excellent assessment, because it'll pick up a lot of those changes that our clients are doing to stand on one leg. And this is what they're doing during their gait cycle, but we don't always pick it up because it's happening so fast and it's such a dynamic process. And that's why I mentioned earlier that videotaping your clients can be a very valuable tool in assessing their gait. So just have them walk on a treadmill, and if you don't have a treadmill available to you, just have them walk in a long hallway and just follow behind them and videotape them. Then play it back and slow it down so you can actually see where they're actually losing control, and things become much more obvious when you start to slow things down. So the principles of the integrative movement system: alignment, breathing, and control. That's how we develop efficient posture and movement strategy. So we're going to make sure that we create optimal alignment. Make sure once we align that we get the proper breathing, the three-dimensional breathing, and then we want to control both the TPC alignment, or that thorax over top of the pelvis, as well as control that lower extremity, the alignment of the hip, the knee, and the ankle and foot. Then we want to take the alignment, breathing, and control and integrate it into the fundamental movement patterns: pushing, pulling, squatting, lunging, bending, rotating, and gait. In this webinar, we're going to look at the glute medius patterns, including the modified clamshell, the modified side-lying abduction pattern, modified side plank, bench step-offs, and band resist step-outs and walks. So, our IMS corrective exercise strategy: train the functional use of the glute medius. Remember, the glute medius primary function is to control the pelvis and hip in the frontal plane. So whether we are standing on one leg, whether we're moving forward onto one leg, whether we're squatting, lunging, we want to control the pelvis and hip within that frontal plane. We want the glutes also to control the lower extremity. So the glute medius, as part of that lateral gluteal complex with the glute max, glute minimus, and TFL, help control the lower extremity. So it helps control the alignment of the hip, the knee, the ankle, and the foot. And we want to control the TPC in single leg stance. So as we get into single leg stance, the glute medius will help control the pelvis, so the pelvic part of the thoracopelvic canister, as we get into single leg stance, and more of the dynamic patterns like the lateral band walks that we'll do later on, and the lateral bench step-offs, which really requires that single leg stance control. Before we get into glute medius exercises that we use, let's look a little bit at the research, because a lot of times research or individuals will talk about the research around glute medius and suggest certain exercise patterns as the best patterns for working the glute medius. So let's look at just a couple studies about the glute medius. And this comes from the Journal of Orthopedics and Sports Physical Therapy, 2009, glute medius activation during common therapeutic exercises. What exercises affect the glute medius the most? The number one exercise this study found was a side-lying hip abduction pattern. So this is where you lie on your side and you lift your leg up to the side in hip abduction. They found that this pattern created the most amount of glute medius activation. So just remember what we said earlier, though, that when is the glute medius most active? When we're upright. It's when we're moving into single leg stance. And even though there may be a component of hip abduction, it's not actually hip abduction that's happening. It's really control of the pelvis over top the femoral head. So I want you to think about lying hip abduction and ask yourself, does that pattern actually improve what happens when we get into the upright position? If it does, then continue to use it. But if there may be a disconnect there between lying hip abduction and what needs to happen when standing up, then we may need to think about how we actually use our glute medius exercises. So now let's look at another study, a more recent study, from the International Journal of Sports Physical Therapy in 2011, EMG analysis of glute med and glute max during rehabilitation exercises. What exercises affected glute medius the most was a side plank with abduction. So again, put the person in a side plank and then abduct the hip, and that created the most amount of glute med activation. But here's my question to you about research. And here's another point I want to make about research. Research is really based upon, or muscle activity during these research studies is really based upon EMG studies or analysis. And EMG just is a fancy word or initials that stand for electromyography. And basically what EMG studies is the activity or intensity of contraction of a certain muscle. So what they do is they hook these electrodes up, or they put a very fine needle into the muscle, to the working muscle. So it's similar to an acupuncture needle attached to these electrodes into the muscle belly, and find out which muscles are working the most during a specific exercise. So in the previous two studies, we saw that side lying hip abduction created the most amount of activity in this one study, and the side lying plank with hip abduction created the most amount of glute med activity in the second study we looked at. But here's what I want you to really consider. What research doesn't tell you is what you are researching, or the muscle that you're researching and the exercise that you're using to work that muscle, is it really doing what you want it to do for your client? Or in other words, is the exercise appropriate for your client, and will it relate or translate into what needs to happen during optimal function? So another way of saying this also, or the question we want to ask ourselves, is this muscle appropriately aligning and controlling the joint when we need it? So what I want you to think about is that lying hip abduction exercise, or even a side lying plank position, does it teach that glute medius to actually control the pelvis and the hip when you get into single leg stance, or when you get into the upright position? And then also, how do you know? A lot of times we just make an observation or a conclusion that because this exercise in the research creates a lot of muscular activity, that it's going to translate into better activity when we get into the upright position. As long as you're proving to yourself, yes, it does, by either some kind of functional muscle testing or some kind of analysis before and after, and you can prove it to yourself, then go ahead and use it. But just think about, does lying hip abduction translate to better control of the pelvis over top the femoral head when the client is in the upright position? And what we found year after year of looking at our patients and clients and really closely analyzing our exercises and the results of our exercises, we found that it rarely does it affect our clients when they get into the upright position. That's why we create a lot of the modifications that we're going to show you in our corrective exercise patterns that we use in this webinar. And here's the side lying hip abduction. We said the pros is it creates glute medius strengthening. However, what I want you to think about is it really doing what you want it to do. So let me cue up this exercise, and you take a look at this exercise, and you tell me what you think about this exercise, and you tell me what you think is a potential problem with this exercise. Leg goes out, and now we go into side lying hip abduction. This is how most people are performing this exercise. Do you see a problem with this exercise the way I'm performing it? And what are the problems with this exercise the way I'm performing it? Well, number one, am I really getting just the glute medius working? And you can see the answer is no. Cue this up one more time. Watch my low back, especially on the side that I'm lifting. See, I go into lateral flexion. There, every time I lift my leg, a lot of this motion is actually coming from my lateral flexion of my trunk. Number two, how well am I controlling my TPC? You see I'm moving all over the place. The leg straight out in this position here in the side lying hip abduction is a long lever arm, meaning that there's a long lever between the weight of the leg and where my glute med needs to control that. And if you look at this pattern, I'm not the weakest guy around. However, even I'm having a hard time controlling this pattern. So now think about your older clients, the ones that have more hip compromise or pelvis compromise or low back compromise, and ask how well are they controlling these patterns. Another thing I want you to look at is, do you think this exercise is really helping your glute med control the position of the pelvis relative to the femoral head? Do you think that this is going to help me when I get into single leg stance control that femoral head underneath the pelvis, or the pelvis over top the femoral head? And again, what we found with the majority of our patients and clients is there is no translation to these exercises and what our client does when they get in single leg stance. However, the other exercises that clients will do are things like the clamshell. And again, the pros for this is it promotes glute medius and piriformis strengthening. Because, again, is it really doing what you want it to do for your client? So let's take a look at this exercise now. So here's how most of our clients are performing this pattern. And what they're really doing is this mindless technique of this exercise. And here's what I mean by mindless technique. They lie on their side, and then they'll just basically lift their leg, and they're rotating their whole entire pelvis and low back. And basically what you're doing is you're training spinal rotation. And then what you want to ask yourself is, do you really want spinal rotation? And again, another question we want to ask ourselves as we're doing this exercise is, will this pattern, even though it shows a lot of EMG activity in the glute medius, I'll cue it up again, showing a lot of activity in the glute medius, is it really going to help your glute medius function better in the upright position? Again, remember the glute medius in the upright position, whether you're squatting, lunging, standing, or standing on one leg, is to control the pelvis over top the femoral head, or control the femoral head underneath the pelvis. This pattern is doing neither. All it's doing is moving the femoral head within the acetabulum. A very excellent pattern to teach dissociation of the femoral head from the acetabulum, but not necessarily improving the ability to control the pelvis over top the single leg. And that's why we don't use a lot of these patterns with our clients. However, we have come up with a modification of these patterns to actually start to increase the glute med activation. We call it the modified clamshell and the modified side-lying hip abduction. And again, the goal of these patterns is we're trying to improve alignment of the TPC. We're trying to improve connection or activation of that glute medius with optimal TPC control. And we're trying to get the person to just neurologically control and find that glute medius muscle. We're not saying this is going to improve function in single leg stance. It's to improve connection and alignment of the TPC, improve connection and activation of the glute medius, so that when the client gets into the upright position, they're able to better find this connection. And we found this to be very effective. So here's what we do. We lie our client on the side and stack their shoulders and legs. So their shoulders stacked back against the wall, pelvis and hips are stacked. We put a yoga block between their knees to keep their pelvis in a more optimal alignment. So then what we're going to do is have the client push their foot flat against the wall. So push the top foot into the wall. And then we'll slowly rotate the hip for 5 to 10 repetitions for 2 to 3 sets. So again, we get an isometric contraction of the entire gluteal complex, and then we perform hip abduction / hip rotation. So I'm monitoring my pelvis to make sure I don't move my pelvis. I got my thumb in my glutes to make sure my glute medius is activating. My foot is staying against the wall to make sure I maintain that hip extension component. So that way I'm getting awesome contraction of the entire gluteal complex as I'm teaching myself to control my entire TPC. Again, the goal here is to align and control the TPC and to activate the gluteal complex with TPC control. What I'm doing also is I'm pushing gently, pushing the elbow and the knee down into the table. So this bottom leg and arm control my TPC. So I'm using my shoulder complex and my hip complex on the bottom side to control my TPC. So that way I can work this top leg. So I'm going to cue that up one more time. So I get myself lined up, push the foot into the wall, and it's a slight abduction and rotation. I don't care how high I go. My primary goal is to control the alignment and control activation as I move my hip into slight abduction and slight rotation. Remember, what we're trying to do is improve alignment, control, activation, so that the person has better sense of what they need to do when they get into the upright position. I'm not saying this pattern is going to control upright position, but I'm developing the control that they need once they get into the upright position. This pattern is great for clients that have knee pain because you can start to load the glutes up and teach them TPC control without putting a lot of stress on the actual knee joint. Now we move into the modified hip abduction pattern. So again, we saw in the EMG studies that the hip abduction pattern was one of the best patterns, or the patterns that the research showed activated the glute medius the most. But remember, I also mentioned that the glute medius' job is to really stabilize the pelvis over top of the femoral head once we're in the upright position. So we're going to modify this pattern so that we start to teach the glute medius how to control the hip underneath the pelvis. So here's what we're going to do with this pattern. We're going to use the same position, the same alignment as before. We're going to lie on the side with the shoulders and hips stacked and the back side against the wall. So your entire back will be flat against the wall. The right shoulder will be about 90 degrees of flexion. The right hip will be about 45 degrees of flexion. We're going to push this elbow and this knee down into the table. So we get activation on the shoulder and the hip complex to stabilize the TPC. Then I place the top leg against the wall so the foot is flat against the wall. So I place the top foot against the wall. So then I slide the leg away from my body while maintaining pressure against the wall. Okay, so I line my TPC up, activate the bottom side. So I push the elbow down and the knee down into the table, push my foot against the wall, and slide the leg away. So therefore, I'm teaching myself to control my TPC. I'm making sure I keep activation of the gluteal complex, and I slide my leg away. So I'm teaching dissociation of the leg with proper glute medius activation. So here's what this pattern looks like. So I'm going to show you from the setup all the way down to completion. So sit on the table, and again, the client can also be on the floor. Support the head properly, so the head is in alignment with the TPC. I get my body all the way up against the wall. Line up the elbow, bring the knee up. So I'm pushing this bottom knee and the bottom elbow down into the table so I support my TPC. My top leg goes up against the wall. Foot stays flat. I'm going to palpate my glute medius to make sure I get glute medius activation. Then I slide the leg out. And again, it doesn't matter how high you go. It's just me. I'm just sliding my leg straight out, away from my body, making sure I keep and maintain optimal activation of that glute the entire time. So that way I get the whole entire gluteal complex working, not just glute medius isolation. So I'm pushing my foot into the wall, slide out, and come back. And if you notice, I pull my toes up, and then put my foot back down on the wall. Perform 3 to 5 repetitions, and then return and rest. The important thing is more the form of the exercise, not how many repetitions you do. Don't go to a point of fatigue. So I'll cue that up one more time. Lie down on the side. So bottom elbow goes at the 90-90 position. So 90 degrees of elbow flexion, 90 degrees of shoulder flexion. Bring my knee up to about 45 degrees of hip flexion. And I push my bottom knee and my bottom elbow into the table for support. My top leg comes up, so my foot is flat against the wall. I'm going to palpate that top glute. I'm going to slide my leg out, raising the foot off the wall, come back to the starting position. Slide my leg out, come back to the starting position. I want to keep my lower extremity aligned. So hip, knee, ankle, and foot stay aligned. And remember, it's not important how high you go. In fact, I'd rather almost like the leg more parallel to the table, not so high up as I'm demonstrating here. Let the leg come more lateral or more parallel to the floor. Perform 3 to 5 repetitions and then slowly relax. Remember, it's more about the quality of the motion versus the quantity. Once your client can do 3 to 5, then you can increase it 2 sets of 10. From there, we can also progress to the modified side plank. This is a higher level progressive pattern. For many of your runners, this is a great pattern and a pattern that they should be able to do. Because again, we talked about the side lying hip abduction pattern earlier, and how that really doesn't necessarily always translate when the legs are out straight. So when these legs are out straight. So what we do is we bend the bottom leg so that the support is on the knee. So that way when the individual planks up onto their forearm and their knee, they're getting this entire bottom side connected from the shoulder complex through the TPC or the core into the hip complex. So we're teaching the glutes to work in conjunction with the core stabilizers as well as the shoulder stabilizers. Here's what this pattern looks like. So again, the client lines themselves up. The TPC is aligned. They bring their knee up to about between 45 and 90 degrees of flexion. They're going to push the knee down into the table. They're going to push the forearm and hand down into the table. And you notice Steven's keeping control of his TPC. They're going to lift up onto their bottom leg, control, and slowly release back to the starting position, maintaining that TPC control. Lift up, come back, and control. And make the client earn that position by holding it up there for several seconds. So they come up, control, and then they come down and control. So cue that up one more time. So again, line the client up and control. Make sure the hip, knee, ankle, and foot stay aligned on both the bottom leg as well as the top leg. Their TPC stays aligned and their head stays aligned relative to their body as well. Do not let your client develop compensations in this pattern. Make sure they earn this pattern and earn their alignment, because this pattern will train dysfunction just as much as it will train optimal function if they do it with poor form. So make sure your client can maintain optimal alignment and control, and this is a beautiful pattern to start to teach the glute medius how to control that pelvis position. Next, we start taking this function into the upright position. So we've done some side lying patterns to improve alignment and control and to start to activate the glute medius. Now we're going to start to bring it up into the upright position. The benefits of the step out pattern is it creates glute medius activation and control of a stationary leg. So what we're really training is the ability of the glute medius and the gluteal complex to control that pelvis and keep it level as we transition our weight from 2 legs to single leg. So we're really working the stationary leg, not the leg that's stepping out to the side. When alternating sides, it controls weight transfer. So it controls the transfer of weight from one leg to the other leg. Okay, so basically what we're going to do is step out with one leg, come back to center, and step out with the opposite side. And it also teaches the control required for higher level progressions. So what this really does is it allows us to take the activation we did in the side lying patterns and transition it to the upright position. Because this looks very similar. If you think about the side lying patterns that we did, if we take it from the side lying to upright position, that's essentially the control we're trying to create. TPC alignment, pelvis level, lower extremity aligned as we step out. So here's what we want to do. We want to ensure control of TPC. There should be no change in alignment. Head should stay in the same place. The lower extremity alignment should remain the same. So hip, knee, ankle, foot stay aligned. And transition from leg to leg. There should be no change in TPC or lower extremity alignment. So let's cue this up, and here's what it's going to look like. So as I step out, you want to see that I control my TPC, and that this leg, or each leg as I step onto it, maintains alignment. Step out, control. Step out, control. And just kind of look at my head position first, and you notice there's no change in my head position. It stays relatively stationary. So if you had a line on the wall, it stays stationary. Next, move down to the TPC. TPC stays aligned. There's no change in TPC alignment. Now look at the lower extremity. So cue that up one more time. Now look at the lower extremity. Lower extremity stays aligned. Hip, knee, ankle, and foot. Hip, knee, ankle, and foot stay aligned throughout the pattern. This is what it should look like. You're teaching your client to control that lower extremity. You can get the gluteal complex, especially the glute medius, controlling that single leg stance or that transition from side to side. Because what happens is when they don't control side to side is the knee moves into a valgus position. So as they step out to the side, you start to see this position. So you start to see the femur come in more into internal rotation and the tibia go into more abduction or external rotation. And that's what creates that valgus position of the knee. What you may also see is them bend that trunk towards that stance leg. So you would see me bending my trunk over top this stance leg. Or what they also do is they'll step out and they'll put all the weight over on this left leg. So basically all they're doing is a lateral step. You want to keep the weight over this leg. You want to keep the TPC aligned. You want to keep the hip, knee, ankle, foot properly aligned through this pattern. Looks relatively easy, and relatively it is an easy pattern, but it's quite challenging for our clients that struggle with single leg stance. Once they control single leg stance in the step out, then you want to step out with band resistance. So again, the same goal here is we want to maintain alignment of the TPC. You also want to maintain alignment of the lower extremity, and you want to step out while maintaining TPC and lower extremity control. So I'm stepping out here, and remember, we're not working this stepping out leg. We're working the alignment and control of the stationary leg. We can also step out to the side. So we want to maintain alignment of the TPC, whether we're stepping back and or stepping forward. But again, remember we're stepping out and working the stationary leg. We want to step out and maintain both TPC and lower extremity control. And here's what it looks like with a band. So from behind, we're going to cue this up. So we're going to step out and watch again. TPC stays controlled. Lower extremity stays controlled. So as I step side to side, my position of my body stays relatively stationary. Pelvis stays relatively neutral. TPC stays aligned. Lower extremity stays aligned. So that way there's no change in my starting alignment, then my ending alignment. So again, cue it up. Again, watch the TPC control. Watch that lower extremity control. So that the band resistance change provides no difference whether I'm stepping out without the band or with the band. So for a lot of our clients, it's about not using a band that's too heavy. Make sure they've earned the right to do this pattern by progressing with the step outs, and then make sure the band isn't so heavy that is causing them to compensate. And from the side, we're going to look for the same exact things. Maintain that TPC, maintain the pelvis, maintain that lower extremity alignment. Step out, control. Step out, control. And if you look at my height of my body stays exactly the same. There's no change. There's no change in my TPC. I want to maintain control through, especially during the transitions from leg to leg. So one more time. Assume an athletic position. Step out, control. Step out, control. No change in TPC. No change in lower extremity alignment. We can also use an oblique step. So again, just challenging multiple planes of motion or directions, or maintaining control with multiple directions of resistance. So again, it's the same concept. Should be no change in my TPC, no change in lower extremity alignment. So I'm going to step out and back and control. Step out and back and control. Alternating each side, making sure that I control each side as I go through my progressions. And again, make sure your client has earned the right to do more advanced positions. So again, one more time, cue it up. Maintain TPC, maintain lower extremity alignment. Make sure there's no change in position as you transition from side to side. You want to really have that minimal weight shift as you transition weight from side to side. Make sure that the knee stays lined up between the hip and the ankle and foot complex. Great pattern to start to change multiple directions of that forward leg. Remember, the most common compensations is a knee moves into that valgus position because the person's not controlling, either the band's too heavy or they don't have the control. So as they step out, you watch the knee go into a valgus position. Or what they try to do is they try to side bend their body over top the stance leg. And that's usually what happens when you start to use a band that's too heavy. They'll start to bend their weight over top their stance leg. It's not about the resistance. It's about controlling that alignment as they step out. So err on the side of using a lighter band rather than using a heavier band. It's no loss to use a lighter band. In fact, when we're doing this pattern myself and with our clients, we're usually using a yellow band. Very few of our clients can actually use a green or blue band. However, if you have those clients that maintain optimal TPC and lower extremity alignment, then go ahead and challenge them with the higher resistance bands. Then we take that into the lateral band walks. And this is a great pattern, really excellent pattern to teach that frontal plane control. And granted, we rarely walk side to side, but this is really a great pattern when performed properly, when performed in a manner that allows your client to control their TPC and their lower extremity alignment. And I want you to really pay attention closely to my TPC alignment as I step out. Very few people, when they're doing this pattern, actually keep their TPC alignment throughout the pattern. So I want you to really pay attention to the TPC alignment as I step out. If you notice, there's no change in my TPC alignment. I keep it, the thorax stacked above the pelvis stays level and parallel to the floor. As I step out, there's no change in my alignment. So again, one more time. TPC stays aligned. Lower extremity stays aligned. I keep myself in an athletic position so that therefore I keep that nice glute activation without getting into that posterior pelvic tilt or excessive anterior pelvic tilt. And I'll make sure that I don't overgrip my hip complex as I'm going through this pattern. Keep nice alignment throughout the pattern. Make sure your client has earned the right to do these patterns. If they can't do the step out, they sure can't do the lateral band walks. Make sure they earn the stationary position before you have them start stepping out into the band walks. From there, we go into our frontal plane step-offs. I love this pattern to start to develop higher level of control. The benefits of this pattern is basically just to reinforce and enhance the mechanics that we've talked about throughout this webinar. Is it gives us isometric control of the pelvis and hip. So really challenging that gluteus medius along with the gluteal complex and control of the pelvis and hip. And it controls the lower extremity alignment. It also helps us with the alignment and control of the TPC. So basically what we're going to do is we're going to line up the TPC, make sure the head is aligned as well. We're going to go into an athletic position. We're going to bend the hip, knee, ankle, and foot, and make sure that this position is maintained as we step out side to side. Okay, so there should be no change in this alignment, no change in body position as we step out side to side. Now, if you don't have steps like these, or the step is too wide for your client, then just do all one side versus doing alternating, in which I'll show you here in a minute. So again, what we're going to do is align the TPC. So get the TPC in line, head in alignment with the TPC. Start in athletic or semi-squat position. So what we're going to do is have the client do a semi-squat, so bending the hips, bending the knees, bending the ankles and feet. They're going to step out and touch their foot without losing frontal plane control. So they step out and touch the foot without losing control in the frontal plane. And I'll also show you what it looks like when they do lose control in the frontal plane. But again, essentially we want to see this alignment throughout their pattern. No change in this alignment throughout their pattern. So here's my starting position, my athletic position, TPC stacked, step out to the side, come back, step out to the other side, come back. I'm just alternating between these two sides of stepping out. Remember, if you only have one step or the step is too wide for your client, then just have them do all one side first and then move on to the other side. So we're going to maintain TPC and lower extremity alignment throughout this pattern. I'm kind of driving this point home because this is where our clients are losing control and are not developing optimal control even though they're doing some of the proper exercises. So again, align TPC, start in an athletic or semi-squat position, step out and touch foot without losing frontal plane control. And here's what it looks like. Get in your athletic position, step out to the side, control. Step out to the side, control. No change in TPC or pelvis alignment. And again, what I can feel is a lot of activity in my whole gluteal complex. And if you notice, alignment of hip, knee, ankle, and foot on both sides. There's no loss of hip, knee, ankle, or foot control as I step out side to side. Generally, we'll do 5 to 10 repetitions per side and then relax. So one more time, just pay attention to the mechanics, the alignment, the control of the TPC, as well as the pelvis, as well as the lower extremity. No change in the alignment of the pelvis or lower extremity. And oftentimes our clients are trying to use steps that are too high, so lower the step. Like that's about the maximum height I can use with optimal control. Any higher and I wouldn't be able to control the alignment of my TPC and or be able to keep my pelvis level. From the side, it's the same concept. So this is the same pattern, just looking at it from the side. So again, I'm going to align my TPC. I'm going to start in my athletic position. I'm going to step out and touch my foot without losing frontal plane control. Athletic position, step, control, step, control, step, control. Notice my position of my TPC remains constant. As long as you're bending your hip and using your hip appropriately, there's no problem with the stresses that are coming through your knee. Our clients are having stress through their knee because they're not getting appropriate TPC alignment and getting their glute to stabilize that position. So watch one more time. So once I get in the athletic position, I sit back in my hips, and that's what keeps the stress from going to my knee. So some of your clients that have knee problems or have problems sitting back in their hips, this is not the best pattern to start with and or to use. Maybe they can progress up to it, but it's probably not the best pattern to use. Begin with just the step out pattern. But this is a great pattern, especially once your client has learned to sit back in their hips and to control that lower extremity and control their TPC. This is a natural progression from those patterns. Just make sure your client has earned the right to get into these patterns and to progress them appropriately. So during frontal plane step-ups, here's the common compensations that our clients will do. They'll either lose control of their hip. So this is me, if a step is too high or I just don't have good control, you'll see the hip kick out to the side. So they lose that frontal plane control through the pelvis and the hip. They can also lose frontal plane control and just have to side bend their body up over top the stance leg. That means that they're not ready for this pattern or the step is just too high for their level of control. Or when they step down, they'll put all the weight down on this leg. So they're not even really training this leg right here. They're actually just stepping down, putting their weight on this leg. Again, still not training control of this leg. And then usually these two patterns go side to side or go hand in hand. They'll step down on this side and they'll laterally flex to get back up. They'll step down on this right leg and they'll laterally flex to get back up. What we want to do, if you remember, stack up the TPC and control this position as you go side to side without any change in this alignment. And again, here's what it often looks like. Just so you see the difference. Is you'll watch me, I'll lose hip control here. Yep, see the hip, the pelvis tilting, hip is kicking out, pelvis is kicking out in the frontal plane. Either the step is too high and or I haven't developed the appropriate progression to get into this pattern. Again, this pattern should only be performed when the client has been able to do the step outs on the floor with optimal control and even probably progress to the band step out with optimal control before you do the frontal plane step ups and or step outs. So here's what it looks like when a client is going to laterally flex their trunk. So here's what happens is they step down and they laterally flex their trunk to get up. Step down, laterally flex their trunk to get up. And usually they'll do a little bit more exaggerated than what I'm doing, but you sort of get the idea. I'm side bending my trunk to get my weight back up, not using the glute medius and the glute complex to stabilize my body and keeping TPC control. I'm just side bending my body side to side to get up over top that step. So again, same thing, non-optimal strategy. So one more time. Lateral flexion of my trunk, lateral flexion of my trunk. Not controlling that pattern. Basically just stepping down onto my stance leg and stepping back up by using my trunk. Not training anything usable here. Maybe getting the client's heart rate up, but not doing anything to improve their glute medius function and or their control in single leg stance. Another pattern that people will use is excessive trunk extension. And I'll show you that last pattern here. Common compensation is you'll see me just kind of be all over the place and I'll just extend up. So I'm not controlling my pattern, I'm just going up. I'm basically just doing a lateral step off and just extending my spine to get back up. Not controlling my TPC. Basically just overextending my lumbar spine at the TL junctions specifically to get myself back up. Barely using my glute medius and or not training optimal control of the TPC and or lower extremity. IMU Expert Checklist. During this webinar, we looked at the glute medius and the relationship of the gluteal complex to frontal plane stability and developing optimal control during activities like walking and running. The important take-home concept was that in order to have optimal activation of your glute medius, you must be able to control the TPC or the alignment of the thorax over the pelvis, and the pelvis should remain level. Many individuals that have inhibited glutes and lose frontal plane control will compensate by either dropping their pelvis to one side and or by side bending their trunk over their stance leg. This will lead to the development of problems such as hip tightness, back pain, and even knee and foot issues. Remember, establish neutral thoracolpelvic canister alignment of the thorax over the pelvis for optimal glute medius activation. Next, we looked briefly at the research and discussed how EMG studies of muscle function doesn't always tell us the entire story of muscle function and whether or not it will help our clients improve function when they get into the upright position. We used modifications of the clamshell, side plank, and hip abduction patterns to improve glute medius activation and hip centration, or alignment and control of the femoral head within the acetabulum. These patterns were modified so we obtained greater involvement of the entire gluteal complex, and by really focusing on the setup position, ensuring that the thorax and pelvis were aligned and controlled during the pattern, we are training both TPC control to provide a better anchor point in order to optimally use the glute medius. Finally, we demonstrated how to improve control of the pelvis and hip complexes by incorporating the concepts from the corrective exercise patterns into functional movement patterns. In this webinar, we included the step outs, with and without band resistance, lateral step offs from a step platform, and lateral band walks to integrate gluteus medius function into the control of upright posture and movement. Recall that it's equally important to ensure alignment of both the thoracolpelvic canister and lower extremity, and make sure your client appropriately progresses through the fundamental patterns that enable them to be successful and to be successful without compensation. And realize, because your client has gotten strong by doing non-optimal strategies, developing the proper control often takes time. So don't be afraid to regress your clients down. You don't need to tell them it's a regression, just tell them that you're working on creating a more optimal strategy for the client, because most of us have gotten strong by using non-optimal strategies. What we're trying to do is just make sure that we're teaching the individual how to align and control in the best position possible. By following this formula, you will help your clients develop improved glute medius strength and control, and you will help so many individuals who haven't been able to walk or run in the manner they want because of tightness and or pain. And you will progress them safely and effectively towards accomplishing their health and fitness goals, whether they are to simply walk around the block with their spouse, exercise with less back or knee pain, or run their annual 5K. And that's how you become an in-demand expert that your current clients will refer their friends, family, and colleagues to. Be sure to check out the IMU Resource Center for continuous support information and updates. This resource center will continue to grow to keep you up to date on the latest information and help you remain informed so that you can be the expert that your clients need and want. And be sure to watch for our own integrative movement specialist, Sarah Fisher, bringing you additional tips and strategies to enhance your learning and success following each webinar. I want to thank you for watching this webinar. This is Dr. Evan Osar of Integrative Movement U, providing you with the perspective, the principles, as well as the best practices you need to help your general population clients achieve, maintain, and perform at their highest level. I look forward to seeing you next time inside the U.